Hi class, this is Dr. Heather Austin-Robillard, and this lecture video is going to be a very brief introduction to psychological disorders that are commonly comorbid with substance use disorders. Again, as a review, this is what you will be tested on in your licensing exam for an LCDC, as well as what we're going to be going over in this lecture video. You will be learning about how to refer to appropriate medical personnel when they have a mental health disorder, the different signs and symptoms of co-occurring mental health disorders, recognizing the need for more in-depth information from other professionals, identification of issues outside the scope of your practice, conditions commonly associated with substance use disorder or other co-occurring mental health disorders. Just a reminder, as an LCDC, we are able to diagnose substance disorders, but not other mental health issues. You would need a master's degree and a license in counseling in order to do that, or psychologists or doctors. An LCDC is not qualified to treat a person with a mental health disorder, or again, provide family counseling to an individual presenting problems that do not include substance use disorders. So within this scope, this is where you would need to learn how to refer to other professionals while also treating them for their substance use disorders. These are the difficulties you may encounter as an LCDC. Mental illness other than a substance use disorder is outside of your scope of practice. The problem there is that most substance use disorders are also comorbid with mental health issues. In fact, you should actually expect that any person that you come across may have a mental health disorder as well. Again, another problem with this is mental health symptoms oftentimes are very similar to symptoms found in intoxication, withdrawal, or the long-term effects of drug use. You will need to know enough information for motivational interviewing in order to raise a red flag that there is a difference between those symptoms for substance use disorder versus mental health issues, as well as acknowledge the need for consultation and referral. There will also be a need for a multidisciplinary team, both in assessment and treatment. A multidisciplinary team is when you have other professionals that you are working with. For example, at treatment centers, you will have a substance use disorder counselor, as well as a psychiatrist, as well as a nurse practitioner or doctor in order to treat physical symptoms of withdrawal and intoxication. Now let's take a look at some of the statistics that we know to show you why you need to understand a little bit about mental health issues to refer out when needed. This is a sample of an epidemiological study where people looked at certain substance use and disorders as well as mental health disorders. As you can see in the red box, alcohol, there was 36% that had any mental health disorder and only 19% that had no mental health disorder. When it came to other drugs, 53% had any mental health disorder and 20% had no mental health disorder. So with alcohol use disorder, you are 2.3 times more likely to have any kind of mental health diagnosis and 37% to have no mental health disorder. Here's a list of all the different types of mental health disorders that have some comorbidity to them. So with any substance abuse or dependence, you will see that there's a 47% for schizophrenia, 83% for antisocial personality disorder, 23% with anxiety, and 32% with obsessive compulsive disorder. In short, you will typically find co-occurring mental health issues like anxiety diagnoses. This can include generalized anxiety disorder, panic disorders, or even PTSD. You will also find mood disorders, depression, and bipolar. There can also be some psychosis or schizophrenia, attention deficit disorder or hyperactivity disorder, antisocial and or borderline disorder. Not to mention, they may experience polysubstance diagnosis, so having more than one substance use disorder. Again, we're going to go through a crash course, but remember, you do have some recommended videos you can watch in this module to learn more about those specific mental health disorders. We are only going to be covering the ones that are commonly comorbid with substance use disorders. So make sure you can consult the DSM-5 for more details about symptoms and criterion. With commonly co-occurring mental health issues, you can ask the question, is there issues with executive control? Do they have trouble making judgment, decision-making, or behavioral control? Those might fall into personality disorders like antisocial and borderline. They may have specific moods and emotions, either too much anxiety, worry, or fear, or too much happy, sadness, or even depression. They may have issues with reality, so psychotic symptoms, hallucinations, or delusions. As for anxiety disorders, these are psychological disorders that feature motor tension, maybe jumpiness, trembling, inability to relax, hyperactivity, fast heart rates, apprehension and fearful expectations or ruminations of thoughts. They can also be maladaptive behavior rituals that reduce anxiety. So somebody with like obsessive compulsive disorder, where they have these compulsions to participate in behaviors in order to manage their anxious thoughts. Other anxiety disorders would be phobias, panic disorders, PTSD. Specifically with post-traumatic stress disorder, 28% of women and 52% of men with lifetime PTSD will also struggle with a substance use disorder at some time in their life. 46% of lifetime PTSD also met criteria for substance use disorder. This can lend well to the self-medication hypothesis, where individuals are utilizing drugs and alcohol as a way to mitigate their PTSD symptoms. When somebody has PTSD, there is a need for trauma-informed care and a need for assessment of prior trauma when you're meeting with individuals. A common anxiety disorder is generalized anxiety disorders. Anxiety disorder that consists of persistent anxiety for a period of at least 6 months, and the source of the anxiety can't be specified. So it doesn't mean they are under a lot of stress, they just feel a lot of panic and worry generally. They tend to worry about everything, and it's difficult to stop or control their worrying. They have difficulty concentrating on everyday tasks. They feel restless, irritable, or have a high muscle tension. This is 2 times more common in women, and the onset is in mid-teens and is usually triggered by stressful events like divorce, death of a parent or a pet or a friend, life transitions. Another anxiety disorder would be panic disorder or agoraphobia. This is recurrent and has sudden onset of intense apprehension. So they may feel dread of dying, pounding heart, trembling, shaking. Some individuals even go in the hospital thinking that they're having a heart attack. Agoraphobia is the intense fear of public places or the fear of fear itself. When working with clients, we want to make sure that we're identifying differential diagnosis, because some of these symptoms can be related to thyroid problems or withdrawal symptoms from drugs and alcohol like depressants, or even intoxication of something like a stimulant. Lastly, another anxiety disorder is obsessive compulsive disorder. This is less common for substance use disorders. However, I felt like it was still important to mention. This phobia is persistent, irrational fear of a specific object or situation. Obsessive compulsive disorder are unwanted, repetitive thoughts, which are obsessions, and then behaviors, which are compulsions, that they feel like they have to do in order to control those thoughts. But anxiety diagnosis in general could lead to dependence of prescribed anti-anxiety medication like benzos, or depressants as a self-medication like alcohol. Mood disorders is another common co-occurring mental health disorder. Among those with a mood disorder, 32% had a substance use disorder. You will also see this as a differential diagnosis because some symptoms of mood disorders can be related to intoxication, withdrawal, or other mental health issues. Mood disorders can also trigger relapse or substance use treatment issues. So you'll want to make sure that you're referring to a treatment that is going to treat both the mental health disorder as well as the substance use disorder. Personality disorders like borderline or antisocial disorder The rates for general personality disorders and substance use disorders are high, from anywhere to 50 to 92%. Among those with borderline personality disorder, 57% received a diagnosis of substance use disorder, 38% was drugs, and 49% was for alcohol. Those with alcohol dependence, 17% of those were men and 8% of those were women with antisocial disorder. Antisocial personality disorder and borderline personality disorder have high levels of impulsivity and risk characteristics, which can lead to substance use disorder. They can also have trauma or an environment of instability, which can lead to poor treatment outcomes. Schizophrenia and psychosis are also common for personality disorders, and they are needed for differential diagnosis and rule outs because symptoms that are caused by intoxication or withdrawal can also similarly reflect schizophrenia, so you need to identify which one is which. Treatment recommendations need to account for this, especially for the functionality of the client. Let's review. Again, LCDs can diagnose substance use disorders, but not other mental health illnesses. You are also not qualified to treat a person with mental health disorders. Hence, there is a need for in-depth evaluation, knowing how to refer to other professionals, and knowing your limitations as an LCDC, as well as how co-occurring impacts the result of the assessment and the recommendations that you have for this client. I know this was very brief, but again, I want to remind you of the recommended videos located in this module to give you some more information of what to notice when a client has a mental health issue. Thank you and have a wonderful day.